Hello everyone, I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. Welcome to Spine Talks, where we bring unparalleled access to world-class experts like the doctors who are joining me on the panel today. Today, we are excited to talk about spinal motion preservation. I am joined by Dr. Rick Geyer and Dr. Domagoj Coric. I'm going to let each of these wonderful surgeons introduce themselves, starting with Dr. Geyer.
Yes, I'm Dr. Rick Geyer, and I was one of the co-founders of Texas Back Institute, and we were one of the first to implant the lumbar artificial disc 25 years ago, and we've dedicated our practice to the development of both cervical and lumbar disc replacement, also with Dr. Domagoj Coric, that I've worked with many times on different studies.
I'm Domagoj Coric. I'm from Charlotte, North Carolina. I was with Carolina Neurosurgery and Spine for 25 years and now work as the director of the Spine Center of Excellence at Atrium Health. And like Rick said, we have about a 25-year history of working together, and it's been a great collaboration. I think between us, we've probably been involved with every major spinal arthroplasty study, both cervical and lumbar, over the past 25 years. And it's been a journey, and it's in this right in the middle of continuing on. We still have a long way to go.
Yeah. Well, I'm so honored to be joined by these pioneers in spinal motion preservation. And we've heard some terms already today that I think would be really helpful to explain. There are words like arthroplasty, disc replacement, lumbar, cervical. It all can be very confusing. But I think if we back up for a second and just think about motion preservation as a concept, the concept there takes us back to 7th grade science class, where we learn about a body in motion stays in motion. And I think for many of us, we think about the spine as a very mobile part of our bodies that probably does better if we can keep it moving. So Dr. Geyer, speak to that concept a little bit.
Well, as you said, Rita, we have cervical vertebrae, which are in the neck, thoracic, which are in the chest, and lumbar, which are in the lower part of the back. And each one moves with each other. So motion preservation is really to keep the normal and natural motion of the spine, rather than doing what was done really since the early 1930s, fusing, eliminating that motion. Motion preservation is to preserve that motion of the spine, of one vertebrae to the other.
That's a great description. And another word that was used is the word arthroplasty. Oftentimes we think about arthroplasty as a medical term when we're thinking about our knee joint or our hip joint. So why in the world are we talking about arthroplasty with our spine, with our back?
Well, arthroplasty, as you've said, Rita, is a catch-all term for motion preservation, basically. And so you can have arthroplasty in total joints. You can have arthroplasty in spine surgery. I think it's a great intro for Rick to talk a little bit, because I'm the resident neurosurgical spine surgeon. Rick, as the orthopedic spine surgeon, can speak to how 50, 60 years ago, they would fuse hips and knees, where today is totally unthinkable to do that.
Yeah, and it's very interesting, because when patients come to see us, we try to explain why the motion is important. And I say to them, if you had a bad hip or a bad knee, and you went to see a hip or knee specialist, and they told you that you would need a fusion, well, intuitively, you would say, I'm leaving this office, I'm going somewhere else, because I know I can get a joint replacement. It's the same way in the lumbar spine. The technology has progressed to the point that we've all said that it's been 25 years since we put in the first lumbar disc replacement, shortly thereafter the first cervical disc replacement. There's advantages to maintaining motion, as you can imagine, but in most cases, or I would say in many cases, a fusion is no longer appropriate, especially for a younger individual, whether in the neck or the low back.
That is just a really, really good description. I can't imagine thinking about fusing a knee so that your knee would be just stuck in one position. That just seems like that couldn't have been possible, or couldn't have been
We used to do them years and years ago.
Yeah. Dr. Coric, you mentioned something really interesting on this panel. You are a neurosurgeon, and Dr. Geyer is an orthopedic surgeon by training. That's something that sometimes patients are confused about, which doctor to choose. How do you choose the right doctor? Should I see a neurosurgeon if I have a neck or back problem, or should I see an orthopedic surgeon? Dr. Coric, can you talk a little bit about that?
It's a little bit of a loaded question, but I'll cut to the heart of it. And my practice, was in a large neurosurgical group, Carolina Neurosurgery Spine, like we talked about 40 plus neurosurgeons. And I have much more in common as a spine surgeon with Rick's practice than I do with the majority of my brain surgery colleagues. In other words, they're clipping aneurysms, taking out brain tumors. That is as foreign to me as it is to Rick, I think. And I trained as a neurosurgeon, I did those things, but it's been 25 years since I've done elective brain surgery. So I've been trained as a spine surgeon, and our training is a little bit different. I think neuro is a little bit stronger in working around the spinal cord and the brain, the neural elements, intradural, inside the covering of the spinal fluid and the spinal cord and nerves. Orthopedics a little bit stronger traditionally in biomechanics and scoliosis surgery and kind of changing the way the spine works. But at the end of the day, you want to go to a trained spine surgeon, whether it's neurosurgical or orthopedic. It's not as big a difference as you would think. It is just kind of a matter of training and how it's approached. But like I said, I have much more in common with Rick's practice and the way that Rick does things than I do with my colleagues who are clipping aneurysms and taking out brain tumors.
Well, Dom was actually very, very kind. But, and I've done a lot of research on this. So when a neurosurgeon goes through their training, they do 400 or 500 spine cases. When an orthopedic goes through his orthopedic residency, they might do less than 100. So as a result, a lot of, all orthopedic spine surgeons go through fellowships to make up that difference between those cases. But still, we don't do tumors, we don't do intradural work, although I do have some orthopedic spine surgeon partners that do that. But generally, that's left to the neurosurgeon. We don't do anything with the head. Yeah. But now, so if you think about it, you have the neurosurgeon, the orthopedic surgeon, and then all orthopedic surgeons do special spine training. Neurosurgeons, in general, they also do more spine training. They'll do enfolded fellowships, meaning part of the residency. And then up here, you have the spine surgeon, that we all do the same thing. But as Dom said, you want to go to somebody that is well-trained. You want to make sure that it's not just an orthopedic surgeon that's replacing your hip and knee joints. That's not the guy you want to operate in your back.
Right. And that's so well described, Dr. Geyer. I think people often wonder, am I at the right doctor? Have I made the right choice for my treatment? Having a specialty trained surgeon is the first place to start. I think another thing to talk about is the kind of operations that surgeon does. Dr. Coric mentioned scoliosis surgery. We're talking today about artificial disc replacement surgery. And I think that patients should ask that question. Does my surgeon do this kind of surgery? And what would you advise patients about that?
Well, it's very simple. As you said, Rita, you should ask if, for example, you are interested in an artificial disc, whether your neck or low back, you say, do you do that? And sometimes they will say yes, and sometimes they'll say no. If they say yes, then what's your experience? How many have you done? You shouldn't be shy about asking, because it's like any other operation. The more that the surgeon does, the better he becomes.
Well, and I'll tag on to a couple of those concepts, Rick and Rita. Number one, a lot of times the surgeon won't be trained or have expertise in spinal arthroplasty or artificial disc, and they'll say, they don't do that, so they'll say, well, that's experimental or investigational. It's not experimental, it's not investigational. These are FDA-approved devices. There's 14 FDA-approved devices in the neck or cervical spine. There's 3 in the anterior lumbar spine and 1, soon to be 2, in the posterior lumbar spine. So number one, if you want to go to somebody who does these, so if all you have is a hammer, everything looks like a nail, and so you want to be able to say, no, you're better off with a fusion or you're better off than arthroplasty, but unless you do both of those, you really don't have the expertise to provide that opinion. So don't just take, oh, well, I don't do that. If someone says that's investigation, say, well, do you do that? What's your experience? And like Rick said, don't be afraid to ask those questions. Don't be afraid to get second opinions. I'm very confident through my career in what I do. I encourage people to send second opinions. If Rick was across the town from me, I would send every patient to him because I believe in what I'm saying and I do. And another good practitioner like Rick provides extra information to the patient. Educate yourself as a patient. And a way to do that is, a lot of patients say, I don't want to hurt my doctor's feelings, get a second opinion. Get a second opinion. Educate yourself. Don't just take someone's word for it. This is investigational. This is not the right thing.
Yeah.
Or they'll say, well, I haven't had good luck with it. And then you follow with the next question, well, how many have you done? Have you done any? And you just can't be shy. It's your body, and there's enough data out there. This is nothing that's brand new. It's a 25-year-old technology. There's a lot of reason why surgeons have not been trained and why they don't do it. Some surgeons don't keep up with the latest technology. They don't go to meetings. They don't get trained in these areas. So you have to be an advocate for your own body.
And if I can tag on to what you said, Rita, you mentioned orthopedic spine surgery, neurosurgery, spine surgery, but they're spine surgeons. There are other practitioners who do spinal procedures, and quite frankly, it's inappropriate. Everyone kind of has their lane in what they do, but this may sound crazy, but if you're having spine surgery, make sure a spine surgeon is doing it, not a pain practitioner or someone who does injections for a living. You're having spine surgery, go to a spine surgeon.
Yeah, well, we live in a world that's very highly specialized. And the good news about modern spinal healthcare is that the innovations that have come along have really revolutionized the field. And as a result of that, surgeons become very specialized in what they do. And so I think that's why it is important to ask, how many of these do you do? And I love that you are encouraging patients to self-advocate, not be afraid to ask that question. And a great spine surgeon who's confident in his skills will never be upset when a patient asks those questions.
No.
And if a surgeon gets upset, maybe that's an indication.
Right. I mean, if I sense that, or as Tom said, just to make it clear, if they say they want to get a second, I always encourage them. I say that if I'm going to operate on you, it's like sending a spaceship up. All the lights have to be green. You have to be confident in me. I have to be confident I can help you. And if you have a lab test that's not right, we're not going. So you have to feel good. And I tell them, I say, I don't want to operate on you because I'm not going to get the best result unless we're all on the same page.
That's great, yeah. So in this highly specialized world that we live in, we are also living in a digital age. So part of what we're doing today is creating patient education information so that patients can advocate for themselves. How does a patient know if an artificial disc replacement is the right procedure for them?
Well, you come to sites like our site here at the National Spine Foundation. You can do research. The internet, unfortunately, there's a lot of good stuff and a lot of bad stuff, and it takes a lot of digging and sifting through. You can go, if you do a general search on artificial disc, I'm sure you're going to get 20 different spine practices, advertising what they do. And they may not necessarily be experts. And I would just say that, you have to find a specialist in your area, ask the important questions, do a little more research, see who's published. Look up FDA trials and see the names. You'll see Dr. Coric on almost everyone, and you'll know that you need to go to see him for an opinion. Yeah. But it's very hard. You can take the opinions of your local docs, and I really believe that 98% of the docs are honest and really good. Yeah. So you go to your local spine doc, and if he's a good guy, he'll say, no, I don't do them, but Dr. Coric does, or Dr. So-and-so does. Why don't you see them?
Yeah.
Yeah, and I agree with that. I think part of the educational process is working through the word salad of all the different things. You mentioned arthroplasty, so let's start at the top. Spinal arthroplasty means spinal motion preservation. So there are a bunch of things that fall in that. Artificial discs are just one of the things. artificial discs are also called total disc replacements. So you will see acronyms like TDR for total disc replacement, or you'll see an acronym CDR for cervical disc replacement, or ADR for artificial disc replacement. These fall in the Rubicon of arthroplasty, but there are different types of procedures. There is a procedure that's now FDA approved, artificial facet in the lumbar spine, which is an arthroplasty procedure because it involves going from the back and taking out the abnormal joints, leaving the disc alone. So that is artificial facet replacement as opposed to total disc replacement or artificial disc replacement. So there are different types of arthroplasty. There are different types of arthroplasty devices. The most common ones are cervical artificial discs. There's 14 FDA approvals, about 6 of which I consider to be modern generation devices. And there's different fits for different pathologies. That's why you want to go to someone like Rick talked about who does these kind of for a living. But it's important to shift through some of that. But remember, arthroplasty, spinal arthroplasty, the big category, then total disc replacement, artificial disc replacement, all the same thing, but facet replacement or 360 replacement means front and back replacements. Those are different kinds of things as well.
And you raise a good point, Tom. Sometimes patients will come to me for another opinion. They'll say, well, the doctor said he's going to replace my disc. I said, is he going to do a disc replacement? Well, he's going to replace the disc. And I said, well, what else did he say? Well, then he's going to put screws in the back. Right. Well, that is not a disc replacement. That is a fusion. But some doctors will use that term, and it's very confusing for the public. You just went through like 4 different iterations how you can get confused by going through the internet. The internet is replete with great information, but also a lot of misinformation. If you go to the patient websites, remember, the good patients are not on there posting about their problem. The bad ones,
Foundation. we tell some good stories.
Right. But sometimes they're talking about all the bad things. So you just have to be very, very careful and trust your trusted practitioners and to help you lead.
That's a great point, Rick. I've gotten more than one chuckle out of this surgeon's recommended a disc replacement. You say, what are they going to replace it with? Now, artificial disc or total disc replacements are typically ball and socket joints that maintain the motion. That's important for some of the biomechanics that Rick can mention just a second, but they say it's going to be replaced with a metallic cage, or they're going to pack full of bone. That's not disc replacement, that's a fusion.
Well, I guess technically the disc space got replaced with a cage.
Yes, but
so it's kind of.
It's a play on words, but you got to be very careful. Just remember the hip and knee joint; those are not fused. What some doctors talk about doing a fusion. Oh, well, I can do a disc replacement, but they're not doing it.
As part of the fusion. Well, so much of what we've talked about today also involves patients understanding a little bit about spine anatomy. So, Dr. Coric, you were talking about facet joints. Huh? What's that?
Well, let's do a quick anatomic review. So the spine has a front or an anterior or a posterior or a dorsal or a back to it. The front part of it, about 80% of your body weight goes through the anterior column or the front of the spine, and that's where the disc resides. So your anatomy is bone, disc, bone. You have 31 of those that go up and down your cervical spine, your neck, your thoracic spine, your mid-back, and your lumbar spine, your low back.
All the way to the hip.
All the way to the hip, to the pelvis. And in the back, you have 2 joints that are facet joints that allow for motion. You get about 20% of the weight goes through the back. So the disc space is called the 3-joint complex. The joint in front is the disc, and one each side is the facet joint. So if you have 6 of those in your low back, so let's use that as an example. So if you do a fusion, what you're fusing is 2 of the vertebrae together. So remember, bone, disc, bone. You take out the disc, you pack it full of spacers and bone, so you have one sheet of bone instead of bone, disc, bone. When that happens, you necessarily lose the motion at that level. So there's two problems with that. One is you have 6 discs in your low back, so you've just lost 1/6 of the motion approximately. More importantly is that those stresses don't just disappear, they have to necessarily go to the levels above and below the fusion. And that's when you hear about folks saying, well, I had an operation, I did well for 3, 4, 5 years, but then I had another operation. It usually isn't, if they did well for that period of time, their operation didn't fail, they've worn something else out. And that adjacent level has seen those extra stresses. And that's what I focus in on the patients. Rick, I don't know about you, but they want to focus in on the motion. You say, hey, the loss of 1/6 of the motion is not the end of the world. Neither you or I are Olympic level gymnasts, but we care what happens to those adjacent levels. We care what's going to happen in 3, 5, 7 years.
And that's a great point, Dom, because when I first started my career, we would do fusion, and the therapist, we do a 2-level fusion. They would have them try to bend over and touch their toes, which was the worst thing in the world because we took away, 40% of the motion. Whereas with the artificial disc, you can maintain that motion. And I tell even my artificial disc patient, I say, be nice to the rest of your disc. Don't bend over and touch your toes. Squat with your hips and knees because we want those other discs to last as long as possible.
Are there some patients whose condition in their spine prevent them from being able to have a disc replacement and for whom a fusion is the right surgery?
Yeah, there's a lot of conditions. We talk about instability, and Don gave a great anatomy lesson. So if you have a problem with your facet joints and one vertebrae slides forward on the other, they're not candidates. We call that spondylolisthesis, and there's different types of spondylo, which is spine, listhesis to slip. So there's different types of spinal slippage. And sometimes because of little cracks in the bone that develop at the age between 5 and 20, sometimes it's arthritic. Sometimes the facet joints are very arthritic, but we rarely see that as a contraindication.
So, we're not saying that the artificial disc replacement is the right thing for everybody.
Of course not.
Not at all.
So you've got to find the right treatment for the right problem.
Absolutely. It is, I maintain that you can be the world's greatest fusion surgeon, but if that's all you're good at, you're not going to be as good a surgeon as someone who can offer both fusion and total disc replacement or spinal arthroplasty, because you're going to fit the pathology to the patient's symptoms, to what operation you're doing and what device you're implanting. That is why you go to a spine surgeon, because they don't just have, a hammer. They have a bunch of tools in the toolbox, and their job is to fit your individual problem with the right operation that's going to give you the best chance to get better.
Yeah, I think that's so well stated that in spinal healthcare, there are no cookie cutter solutions for people. Each person's body is different. Every spine is different. And a well-trained, excellent surgeon is going to have a toolbox, an armamentarium of things that they can offer to fix whatever the problem is that a patient has. You talked about the spondylolisthesis, the slippage of the spine, where maybe there's too much motion. So you wouldn't preserve that motion, you would try to stop that motion, stabilize that motion. And that's where the fusion would be the right operation.
We do have artificial facets, though, so we have an ability to do
so that's what
posterior. And
That's
so,
a new thing.
Yes, the first
a new
FDA
thing.
approval was just last year, and so that's the first FDA approval for a posterior facet replacement that goes from the back. And again, it's an arthroplasty device, but it's not an artificial disc, it's an artificial facet replacement. And so it can be difficult to wade through all the terminology. Like we talked about, spondylolisthesis is one of the most commonly misunderstood and mispronounced words, I think, in the history of spine surgery.
And spelled.
Yeah, but spondy means body, listhesis means slippage. It's that simple. And the question is, why do you have slippage? You've worn out those facet joints, and the body now is slipped forward. It's not like you had trauma and you have an acute instability, but it's what we call a glacial instability, or a slow chronic motion in the spine. But it doesn't make any sense to put in an artificial disc when the disc is perfectly good. The problem is the facets. So, but then you can do an artificial facet
Yeah,
replacement now.
that's incredible. The technology just keeps improving and changing. And so when a device is approved by the FDA, is it still experimental?
No, not at all.
So let's
because
talk about that.
Well, in order for a new device to come out, it goes through very rigorous testing. First of all, the companies have to prove that biomechanically it's been tested to last a minimum of 10 million cycles, which I forget how many years that translates to, but they're supposed to last for 40 years, but that's another story. And they have to make sure they do some preliminary trials, make sure that it's safe, and then they go through this rigorous study. They have to get a minimum of 2-year follow-up, and then they submit to the FDA saying, look, this is safe, we've had a good track record, the patients are doing better, and then they will submit to get it approved. Once it gets approved, which can take another year or so, then the general public, when I say general public, general spine surgeon, would get access to utilizing that device.
And Rick, you bring up a great point, because the concept of experimental, we're not experimenting on anyone. We're not putting baboon brains in baboon thighs in humans. We're doing investigations. So like Rick said, this is a process that typically, to get through the FDA process, which is called for devices, Investigational Device Exemption Process, or IDE, Investigational Device Exemption, typically takes about 6-7 years, takes about anywhere from $30 to $60 million. It involves biomechanical studies, animal studies, preliminary studies in humans, big studies in humans, and ultimately it's a process that takes 6, 7, 8 years. So this isn't like Rick thinks of something in his garage and goes in and experiments on this, and that's why it's investigational. But once it's approved, it's no longer investigational, and that's one of the tricks the insurance companies like to play. They just say, well, it's experimental. Nothing's experimental. We investigate these things, and when the FDA says they're safe for human use, they're no longer investigational.
Yeah. So, Dr. Geyer, what should a patient do if they qualify for an artificial disc replacement and they come to your office because they hear you're great and they live in Texas and they want to have the surgery and all the tests for liftoff show that it's going to be a good thing, but then the insurance company won't approve it?
It's a common problem, unfortunately, and it's becoming more and more common. So we have to do what is called a peer-to-peer review. So in other words, I will get on the phone, I will talk to a doctor that works for an insurance company that sometimes they are spine surgeons and sometimes they're not. And it becomes sort of a negotiation. They'll say, did the patient have this? And the answer is, of course they did. And did the patient have that? Or the MRI showed multiple level disease. Well, unfortunately, with the FDA trials were for symptomatic disease, but the insurance companies have taken this thing and they've made their own decision beyond what the FDA has approved. And it becomes a fight, and sometimes the insurance companies absolutely will not approve it. This is the frustration that the population has today, and Dom has it, I have it, and we do the best we can. We'll do the appeals, and there used to be a separate company that would do it, and now there's another company out that Kim Norton runs that will help do this. But it's very frustrating for the patients. I give you an example. I had a patient that it took 1 year for us to get approved.
Wow.
She woke up in the recovery room and she hugged me and cried, and she said, "Thank you for sticking with me. Because I didn't want a fusion." And it's really a shame, and I hate that our patients have to go through it, because he and I and all the rest of the orthoplastic surgeons, we're only trying to do the best for the patient.
Yeah.
At the end of the day, the National Spine Health Foundation is a patient advocacy group. And this is not to be self-serving. I know we're here talking about that. But the point is, their goal is to help patients be empowered to get access to technologies that are safe and effective and approved by the government via the FDA. So remember, patient advocates are your doctor, your surgeon, and groups like the National Spinal Health Foundation.
Yes, thank you, Dr. Coric. That's right. We are here to bring the patient voice to so many of these discussions, and we can't do that alone. We're so grateful to the experts for joining us in that mission. And being able to provide this education and to hear that directly from the experts is truly a gift. And we are so grateful for you taking the time. We are at a conference where new technologies are being discussed, where the surgeons and the scientists are evaluating what's best for people, what's next on the horizon. And these are really busy times, and we've been able to capture your time here. So we are very, very grateful for that. Any last pearls of wisdom for our audience?
No, I just think that, as time goes on, we're trying to use more natural treatments for patients. And in terms of spine, we're trying to preserve motion. And, the scoliosis surgery, even they are starting to talk about some variation of using motion preservation with their fusion devices. So Val and I have devoted, a quarter of a century of our careers to this, and we believe in it. The patients do great, and I'll never stop advocating for it.
That's awesome.
Well said, Rick.
Dom, any closing pearls from you?
Well, I think it's been well covered. One of the things you mentioned, we're at one of the Spine Summit, one of the largest meeting of both neurosurgery and orthopedic spine surgeons. And we had two of the foremost surgeons in the country, one orthopedic and one neurosurgery trained, get up and talk about what they thought the future was going to look like in 2030 and 2050. Both independently mentioned spinal arthroplasty, spinal motion preservation as a direction that they were headed. Interestingly, neither of them do spinal arthroplasty, but they recognize that this, like Rick said, this is much more natural for the spine. The spine is meant to move, and when you do a fusion, you're doing something inherently unnatural. Sometimes you have to do that, tumor, trauma, etc. You don't have a choice, but the spine is meant to move, and if you can finish a spine surgery, effectively decompress your nerves, and get the patient doing better, and then can leave them like you found them, which is motion in the spine, they're going to be better off.
We are so grateful to Dr. Coric and Dr. Geyer for their many years working in spinal healthcare and treating thousands and thousands of patients whose lives have been improved. We call people like you healthcare heroes for what you do for people, dedicating your lives to making other people's lives better. And I can't thank you enough for your time today.
And thank you, Rita.
Thanks, Rita.
And thanks to the foundation.
Thank you.
Absolutely.
Thank you.